Yes. So it is more common in rural condition, and we know that nuclear cataract, subcapsular cataract, they are all due to ocular ischemia. Incidence of cataract surgery is significantly higher. Iris subluxation, lens subluxation is 8.4 to 10.6%. 50% of the patients, they have glaucoma, mostly secondary open angle glaucoma. There is an increased risk of glaucoma by 10 times. There is a significant proportion of patients have astigmatism. 50% of patients have glaucoma, we already discussed, and this is the level 1 evidence that there is a significant astigmatism in pseudoexfoliation. So can we consider toric IOL implantation with Phaco trap for patients with pseudoexfoliation cataract with astigmatism and glaucoma? Yes or no? Yes, we can do it. Trab is a very commonly done surgery, but before implanting toric IOL with Phaco trap, there are certain pre-op evaluations of jonular weakness, which is very important, like shallow ACD and in supine position ACD depends. And most important thing is when you do slit lamp examination, there is a gap between lens and iris. Poorly dilating pupil is not necessarily an indicator of jonular dialysis. There are certain per-operative considerations also, like good akinesia, never a tiny capsulorhexis, complete hydrodissection is very important. We should keep ready CTR, iris expanders, VR backup. And when we don't see any jonular dehiscence and we miss it pre-operatively, we can sometimes find it when we start jonular capsulorhexis and we find there is a wrinkling of the capsule, and that is indicated of jonular weakness. At that time also, we can shift to monofocal IOL. So a CTR has a dual purpose, but there is no evidence to say all eyes with pseudoexfoliation require CTR. So if there is a progressive weakness of jonules, yes, it is there. So it may subluxate or dislocate. But whether monofocal IOL or toric IOL, then why deprive the patient from toric IOL and its advantage? This is a small video clipping. Toric IOL has been implanted, and trap is being done with the trabeculectomy punch. The flap is sutured, the conjunctiva is sutured. You can see the 6 years follow-up of the same patients. There is a little phimosis-like effect. And this is the Varion sheet 6 years back. And on the right side, there is a retroillumination slit lamp picture of the same patient in dilated situation. You can see there is a IOL is at the same position. Actually, the main important thing is we have calculated Phaco trap SIA in our hand. Mind you, I am stressing Phaco trap SIA, and we put Phaco trap SIA in all our situations. So this is a comparative analysis of refractive outcome of toric IOL in post-combined surgery SIA group and post-Phaco SIA group in pseudoexfoliation cataract and glaucoma and astigmatism in our hand. So in the most important inclusion criteria is no pre-op and intra-op sign of jonular weakness, 5.5 dilatation, astigmatism more than 2 diopter. This was a prospective comparative study, single surgeon, tertiary eye care. Group 1 was 40 eyes, toric IOL with post-combined SIA. Group 2, 40 eyes, toric IOL power calculated with post-Phaco SIA only. We found, based on centroid value SIA was calculated, we found that post-Phaco trap SIA was low, 0.21 and 0.23, and post-Phaco SIA was 0.5, 0.54, because our primary incision is maybe because 150 degree and our trap is at 90 degree always. So this is the spherical equivalent, K1, K2, axial length, all comparable. Outcome measures photopic and mesopic UCDVA, BCDVA, spherical equivalent, intra and intergroup anterior chamber depth, residual astigmatism. So we found that comparative analysis of pre-op and 3 months post-op anterior chamber depth in group 1 and 2 was comparable. Intra-group comparative analysis of pre-op and 3 months post-op anterior chamber depth was also comparable. So post-op spherical equivalent was significantly better in group 1, that is post-Phaco trap SIA group. Post-op residual astigmatism was also significantly better in group 1. Photopic uncorrected distance visual acuity Photopic best corrected distance visual acuity were significantly better in group 1. Mesopic uncorrected distance visual acuity and mesopic best corrected distance visual acuity was significantly better in group 1. So after adding post-Phaco Trab SIA, we can implant toric IOL at the same sitting with Phaco Trab, resulting in optimum refractive result. For that, you have to calculate your own SIA for this also. And the post-op, it needs intensive post-op care, increased inflammation, IOP spikes, capsular phimosis. So all we need to shoot this triple problem is extensive discussion with the patient, appropriate meticulous clinical evaluation, and careful post-op care.